Okay, so welcome, guys. Thank you all for joining on a Friday night. So today we're going to go through a bit of ABGs, chest X-ray, and also some abdominal X-ray bits towards the end. I'll try and make it as smooth as possible to try keep it towards an hour, but there's quite a lot to go through, so we will see how we go. So if you guys all scan the link on the screen to the Socrative, and then there's two questions on there that we'll use to start off with, just to see what you guys know about ABGs. So whenever you're ready, just give those a go. The first one being, what are the most important points to observe in an ABG? Just wait for a couple more of you to answer. But first answer is very good. Yeah, all good answers. Well done. So, of course, on your ABG, um, you have a variety of bits that you'd want to. What's the next answer that come in? Depending on the reason for doing ABG, yeah, yeah, type one or type two respiratory failure, very good. pH, PaC2, PaO2, and bicarb. Yeah, all very very good points. So there's quite a lot of information we get on ABG. On the right here, you just have an image which shows you what an ABG looks like when it comes out of the blood gas machine. So you get pH, PaO2, PaCO2, um, lots of different electrolyte values, hemoglobin values, glucose and lactate, which are always important. And you also get your base excess and bicarb readings, all of which you guys mentioned. Very well done. And these are all important based on the different indications. So the next question is, wait, when may an ABG be indicated? When are ABGs useful? Pray for a couple of answers to come in. Yeah, good to determine if a patient's in type 1 or type 2 respiratory failure. Um, if they have low SATs and you don't know why. So, for example, if a patient comes in acute respiratory distress, you might do an ABG to see the extent of that. This is relevant in like our asthma patients, our COPD patients. Yes, COPD exacerbation, very good. I think those are probably the most common questions which generally come up. A lot of stuff on PassMed about type 2 respiratory failure, but also highly relevant to determine the extent of like an acute asthma situation. So you'd use like one of your signs of near fatal asthma is if your um, PCO2 is normal or high, and because that would be suggesting of fatiguing of the respiratory muscles. And also in acidosis and alkalosis. So, for example, overdoses, things like diabetic ketoacidosis will also, an ABG will be very important in these situations. When someone who may have drunk a lot of alcohol comes in quite drowsy, I think I said overdose. That's also very relevant, but very good, very good. So yeah, on the slide in terms of when an ABG is useful, it's a good point to mention that you don't always need an ABG. Um, it's much less invasive. ABGs are really painful. I imagine you guys have done them in skills lab by now. They're really painful. In an emergency situation, ABGs are really important and are required to make that diagnosis of respiratory failure. But VBGs are usually okay in non emergency situations. And of course, your standard oxygen sats will be your first line if you just want to check the oxygen sats. But yeah, if you have patients in severe shock, you might do ABG. If you had severe acid-base derangement, which someone said as an answer, you might do an ABG. And if you have severe hypoxia, again, like in your asthma exacerbations, you may do an ABG to get a better idea of what's going on with your patient. Geeky Medics have a really good video on how to do your ABGs for like the clin skills part of your exam. I don't know if an ABG can come up this year, but like it's really good to know how to do one, and you'll have to have one signed off before the end of 6th year. So check out that video, and I think the med school have some good videos as well. So in terms of interpreting your ABGs, there's a lot of information, like we said, it can be overwhelming. So this is your system in terms of identifying everything that's important on your ABG. Start by looking at the oxygen. Is that low? Is that high? The pH, again, is this an acidosis or an alkalosis? And then you look at your carbon dioxide and your bicarb to help to determine whether this is a respiratory cause or a metabolic cause. And then the fifth one, why? It's always important to interpret these results within the clinical context, within the vignette that you're given. And you want to make sure that those things line up, basically. And the information you're given in your vignette will likely kind of lean you towards what's going on even before you've read the ABG. So take all those parts of information that you can before you even get started in interpretation. So it's the most important thing in the ABG, the thing that's going to probably kill you first is the oxygen. So using the normal values, a partial pressure of oxygen less than 11 indicates, as you can see on the slide, I have all the what do you call them? All the normal values there. And also in this context, it's important to interpret whether someone is on added oxygen, because of course, room air, you have 21% oxygen, but there's a variety of different oxygen delivery devices which are generally used in ED. And for example, if someone is still on low oxygen and has quite a high oxygen requirement, that situation will be much more severe than someone's oxygen who is the same but has no requirement and is saturating on completely on room air. So those are the main things to take from this slide. If hypoxic, is it respiratory failure? So as like someone mentioned, type 1 or type 2 respiratory failure, oxygen is low in both, but your PaCO2 will help you to determine which type of respiratory failure you're in. So type 2 respiratory failure being mostly associated with like COPD. Type 1 respiratory failure can be associated with other conditions, maybe overdose, other types of respiratory failure. So once you've assessed the oxygen status, the next thing that you want to assess is the patient acidotic or alkalotic? Because again, the first thing that's going to kill your patient is the hypoxia. So, I mean, next year you guys will learn kind of an A2E assessment, and the first thing you assess is always airway. The second thing you assess is your breathing, and then you kind of move on to everything else: circulation, disability, glucose, all those other bits. But your hypoxia is going to kill your patient first. So that's why that's the first thing you check. That's the first thing you observe. And you may see on an ABG, the oxygen's really low, PO2 is really low. So you go and then change their oxygen, and you might put them on a higher oxygen requirement. But yeah, the next thing you'll look at is your pH to see if there's acidosis or alkalosis, and then you'll have a look at your PCO2 and compare that against the normal values. Is the pH low due to a really high CO2? or is the pH high due to a low CO2? And that will suggest a respiratory cause. Of course, there can always be respiratory compensation, which we'll go into later. And then the next thing you do is want to look at your bicarbonate. Does the pH change in the same direction as the bicarb? Is the pH low and the bicarb is also low, or is the pH high and there's a high bicarbonate concentration? And that might suggest a metabolic cause. Of course, um, you can have ions in the blood which aren't bicarbonate, which might affect your pH. Well, first of all, being CO2, which forms carbonic acid, but of course, things that you overdose on, such as what are the things I remember from last year? Ethylene glycol comes up, paracetamol overdose comes up. So these things will affect your base excess, and you'd know whether there's a an acid that you don't have accounted for within your ABG reading. And here's a little graph which is quite useful to help interpret. So is the pH low? Is the pH high? Then your next thing you do is look at your PCO2. And if your pH is low, your PCO2 is low, then it's likely a metabolic cause with respiratory compensation. If you have low PCO2, sorry, low pH and high PCO2, then it's likely a respiratory cause. And you can follow the graph the same on the other side. So this is a really useful graph to kind of break the ABG down into really simple terms. And if you remember this kind of in your exam, then you'll have no problem interpreting ABG and coming to the correct conclusion. And here's a nice table which summarizes the four different causes, or the four different kind of conditions that you want to look at with an ABG. So respiratory acidosis, you have low pH, high PCO2, and then a normal or high bicarbonate, depending on whether there's compensation. Respiratory alkalosis, you have high pH, low PCO2, and then a normal or low bicarbonate as well. Metabolic acidosis, everything will be low, low pH, low PCO2, and then low bicarbonate. And the way I like to think of this is the bicarbonate is buffering whatever acid is causing this metabolic acidosis, whether that's a lactate and whether that's an exogenous acid. And then metabolic alkalosis, everything will be high. So your pH is high, PCO2 high, and bicarbonate also high. And then this is a mnemonic that some people find useful. So I've got the next question on Socrative. What are two examples of compensation, and give a clinical example for each? Let me go back. I think a few more people have joined. So those of you that are on the Socrative, join that, and I'll flick the slides back to the barcodes so anyone who's new to the session can join as well. So I'll give you guys a minute or so to give those examples. Yeah, very good answers so far. So yeah, very good answers. Just to read out a few: respiratory compensation in metabolic alkalosis, you may breathe more slowly. Um, in metabolic, and obviously the CO2 helps to buffer that. Metabolic compensation, um, in respiratory acidosis, the kidney may retain more bicarb to buffer, and the kidney can also retain more acid in um, a respiratory alkalosis as well. Respiratory compensation, cuspal bleeding in DKA, very good. And in metabolic compensation, and that's the key. Probably those are maybe the most key two. Cuspal breathing in DKA for respiratory compensation to the acid, and metabolic compensation, COPD with high bicarb. So very good examples. And this one, more acid loss in urine as well, very good, and more bicarb reabsorbed. Yeah. So good answers, very good answers. Um, so yeah, just because the pH is normal, it doesn't mean everything is normal. So if you're given the normal values, just make sure you're comparing against them. Um, the compensation is your body's way of trying to restore pH back to normal, because in terms of things which are going to affect your body, first hypoxia, second pH, and your body has this very tight range for pH for a reason, to help all enzymes and all the reactions that go on in your body, so they can all happen at their optimal rate. So metabolic compensation occurs by changing bicarbonate, um, via renal reabsorption or excretion, and this the key thing is this happens over a longer period of time, generally takes days, whereas your respiratory change can occur almost immediately by regulating the PaCO2 with hypo or hyperventilation, and this occurs within hours or even on a shorter time scale. To be honest, respiratory compensation can be very quick. I mean, I guess the ABG would change over a period of hours, but in terms of the initial change in breathing, it can be quite quick. So this is what I was mentioning earlier about making sure to read the clinical content. I don't think you'll ever get a question in exams which will just give you an ABG and say, just read it. Even in an OSCE, you'll always have your OSCE scenario beforehand, and you might be given the ABG in the last 2 minutes, or you might be given the ABG on the door, but you'll say your patient comes in with this or with this, kind of take a brief history and talk through the ABG. Um, so there's a very wide variety of things which can give you a clue. A history of anxiety might suggest respiratory alkalosis, because this happens due to hyperventilation, and that leads to breathing off excess CO2, which will then increase your pH. Like some of you mentioned, in diabetes, think DKA. In COPD, you can get an acute on chronic presentation. So you can have a compensated respiratory acidosis, but currently have an acute flare up, which makes things decompensated again. Um, and therefore, those patients have like less of an ability to compensate, given that their compensatory mechanisms are already working long term, if that makes a bit of sense. And some false normals here. Normal oxygen while on high flow oxygen is a worry, a red flag, and a normal PaCO2 in an asthma attack is always, always, always worrying. And I think the way that it was told to me is, if a patient with asthma during an asthma attack has a normal CO2, then get on the phone to ICU. It's kind of that's serious. It's life threatening stuff. So yeah, next slide. Your causes of type 1 and type 2 respiratory failure, which many of you guys mentioned earlier on. So type 1 respiratory failure, you have a failure in gas exchange or a VQ mismatch. So a match between the perfusion and the delivery of oxygen to those areas of your lungs. So that can happen in pneumonia, pneumothorax, pulmonary edema, pleural effusion, PE. You get type 1 respiratory failure, and type 2 respiratory failure is a failure in ventilation. So COPD, asthma, opioid overdose, neuromuscular disease, So those are all your type 2 respiratory failures. And I think the most common ones you'll see will probably be type 1 pneumonia, and type 2 COPD and asthma. So I just try and commit some of those to memory if possible. And here is a graph summarizing your causes of respiratory acidosis, alkalosis, metabolic acidosis, alkalosis. So again, in terms of questions that I can remember last year, your most important metabolic acidosis, either exogenous acids like a lactic acidosis or a DKA. Metabolic alkalosis, you'll get a patient who comes in with, recent gastroenteritis or something along those lines, and you'll have a metabolic alkalosis due to vomiting out stomach acid, as well as having a hypokalemia and a hypochloremia, because you're vomiting out all of those important electrolytes for your body. Respiratory alkalosis mostly will be hyperventilation and anxiety type symptoms. So just make sure you always ask, what's your past medical history, because these, if you're not thinking about it, it can come across as some kind of respiratory infection. But there'll be no temperature, the chest will be clear bilaterally, and you kind of want this to be a diagnosis of exclusion, really. And then respiratory acidosis, severe acute asthma, COPD, and opioids would be the most important ones. So this is a thing which has always confused me a little bit, and it's quite hard to get your head around. So I would suggest kind of like watching there's some really good videos on YouTube to help explain the anion gap. But it's a value which the main point of it is to assess whether a metabolic acidosis is being caused by anions which aren't measured. So again, like your DKAs, like your ingested substances, and there's a variety of causes in here, causes which can cause a raised anion gap, causes which can cause a normal anion gap, metabolic acidosis. And what you do is you add together your sodium, you add together your potassium, and then you take that away from all of your main negative ions, which is your chloride and your bicarbonate. And that generally should be between 15 and 20. And that's just because those are the ions which are really easy to measure. Those are the ions which come up on your ABGs, and those are the ions which are most abundant in the blood. So if you have a raised anion gap, then you have something unaccounted for. And like your examples here, alcohol, DKA, and also starvation, where you can have ketones which affect this balance, uremia, so you can have salicylates which affect this, methanol overdose, well, not overdose, but methanol consumption. And there's a variety of things, and ethylene glycol, which is antifreeze, which for some reason comes up all the time. Well, more regularly than you would have thought on past med, and in like exam questions. So just to summarize ABGs, your fail-safe system, fall back on this if you're not sure. If you get an exam, you panic, just remember, make sure to go through these steps. Are they hypoxic? Are they in acute respiratory distress? Then go on to your pH. Are they acidotic or alkalotic? And if the pH is normal, just have compensation ready in your head for the next two steps, which is PaCO2. Is that driving the imbalance? Then maybe it's a respiratory cause. Otherwise, is it bicarbonate, or is it another base or another acid that you haven't got accounted for within your scenario? And then use the clinical context to help you put the whole picture together. So a couple of MCQs. Your first question, it's on Socrative now. So a 60-year-old man with COPD presents with drowsiness. The ABG shows pH of 7.28, so slightly low, a PaCO2 of 8, so slightly high, and a bicarbonate of 28. What is the most likely acid-base disturbance? Wait for a couple more of you to answer. So you have a bit of a split on answers. A couple of you put chronic respiratory acidosis, and some of you put acute respiratory acidosis. So the answer is chronic respiratory acidosis. So to start off, oxygen isn't given here, but that would be your first step. Then your next step to look at the pH. We have an acidosis picture, and then we have a bicarbonate, a carbon dioxide, which is increased. So increased carbon dioxide, and all of you got that this was an acidosis, and that is as a result of the carbon dioxide, so respiratory acidosis. The thing that tells you whether this is acute or chronic is both your bicarbonate and your clinical scenario. So your bicarbonate is 28, which is high, it's above our normal range. If this was acute respiratory acidosis, we'd expect the bicarbonate to be normal because the body hasn't had time over several days to increase the bicarbonate levels to that extent. And our clinical scenario gives us that clue because we have a man with COPD. Therefore, we know generally he would run at a higher CO2, and generally he would have um, a higher bicarbonate over a chronic period of time. So your second question, a 45-year-old woman presents with a history of persistent vomiting, and she presents for evaluation. Her ABG says pH 7.43, PaCO2 6.8, and a bicarbonate of 32, and your normal values are all on the slide. What is the most likely acid-base disturbance? Just remember to go through your system. We'll just wait for a couple more of you guys. Okay, well done. So all of you that answered got that one right. That one was a metabolic alkalosis with respiratory compensation. So to go through this question, we have a high pH. Well, no, it's high normal. We have a high normal pH. Um, we have a CO2 of 6.8, which is high, and we also have bicarbonate, which is high. So if we go through our stages, the carbon dioxide. So we don't have our oxygen. We have our pH, which is high. Our clinical vignette says persistent vomiting, which gives us a hint towards a metabolic alkalosis, because we're vomiting out a lot of that acid. And what we have here, as the pH is moving towards the alkalosis end, we have quick respiratory compensation with an increase in PaCO2 over normal. And we also have a high bicarbonate, which agrees with our higher pH, which is therefore why we have a metabolic alkalosis. And our carbon dioxide is out of range because we have respiratory compensation over the short term. So well done to everyone that answered. That was all correct. So now we'll move on to interpreting chest x-rays. So I'll give you another chance for any of you guys to join the Socrative who haven't already. And we've got two questions on that. Firstly, why would a chest x-ray be needed? What's the point? What's the point in a chest x-ray? Why do we do it? Yeah, good first answer. Any reason you guys can think of? There's no silly answers at all. Yeah, good answers, good answers. So yeah, some reasons that you guys have said that chest X-rays could be needed. If you have shortness of breath or a cough, you might want to do a chest X-ray to check. Might want to check for signs of infection. You might want to check for different kinds of cancers. This is a very good answer that's just come in. Um, Patient presenting with chest pain or shortness of breath. Some lots of differentials on here: pneumonia, pneumothorax, pulmonary edema, pleural effusion, to check for cancers. Look for fractures, which is another good one that people might not remember. We'll go through an approach in this, but fractures can go missed on chest X-rays because people are looking towards the lungs and looking for pathology here. But actually, one of the chest X-rays that was shown to me towards the beginning of my fourth year was a completely normal chest X-ray, and the one of the consultants gave it to us. They said interpret this chest X-ray, and we were looking at the chest, we were looking at the heart, and we couldn't find anything on there. And then he told us to look at the humerus, and there was a humeral fracture. So that's how these things can get missed. So it's always important to have a wide differential and to be observant for anything. And another thing that someone said was to check for NG tube placement, which is correct. And what are the important things to look for in a chest X-ray? Does anyone have any kinds of structures that they've been taught or they tend to use, or even just a list of important places to look on a chest X-ray? Yeah, very good. First answer smashed it. I'll just give it 30 seconds more and then we'll move on because we're going to go through it anyway. Yeah, very good. Very good second answer as well. So we'll move on because we're going through it. So for an OSCE, your structure for describing a chest X-ray, first of all, patient details. Second of all, film details. Is it PA? Is it AP? Um, what's the patient's name? When was the X-ray taken? Like you guys have mentioned, ripe. So you check your rotation, inspiration, penetration, exposure, all your technical aspects, just so you know that this is a proper chest X-ray. It's well done because over the years you'll see some pretty bad chest X-rays. And then your key structures. A lot of you have said in A2E assessment, which is on the PowerPoint, and we'll go through in a little bit of detail. But airway, breathing, cardiac. Look at the diaphragm, and then look at everything else. And see, these are some of the key review areas that you want to assess. Particularly important ones that people can miss sometimes. I think the diaphragm's always a good one. To look for pneumoperitoneum, you can look for pleural effusion, you can look for um, yeah, look for signs of a pneumonia because you just have blunting of the costophrenic angles there on the diaphragm. And behind the heart, sometimes you can get cancers which hide here behind the heart. And as well the clavicles, which are important for your technical aspects, but also to see any signs of any breaks or anything like that on a clavicle level. But yeah, first patient details, name, date of birth, when the X-ray was taken, and the presenting complaint or the indication if you know it. Um, Second one, the film details, is it AP or PA? If in doubt, it's probably PA if the patient, because that's like your standard. If your patient has loads of wires and your clinical scenario is the patient's really, really unwell, then it's likely AP and supine because the patient is unable to mobilize to go for an erect or a stood up PA X-ray. And PA just means the X-rays taken from the back and the X-ray travels through to the front. Um, it changes the size of the heart. That's your main thing. So heart is difficult to assess on an AP, but that's the main thing. Your technical aspects, like plenty of you guys mentioned, rotation, are the medial ends of the clavicles equally spaced from spinous processes? So is your patient pointing straight on? Inspiration, can you see 5 to 7 anterior ribs? So those ribs that are from the side moving kind of downwards. I think there's a posterior ribs number as well. I can't remember what that number is. Maybe one of you guys know, but there's a number of posterior ribs you can count if you find that easier. Penetration, can you see the spine through the heart? Because that's your sign of penetration. And exposure, can you see the aphyses and the costophrenic angles? And I think one thing that's important with like exposure, does it look weird? Does it look too dark? Does it look too light? Are you struggling to make things out because of that kind of color? So those are the kind of technical aspects which are important. And you always want to say in your OSCE, because there'll be a mark for each one, mark for rotation, inspiration, penetration, exposure. So when you go in, do your wipe system, patient details, when the X-ray was taken, the indication for it, then always go through these technical aspects because it will most likely be 4 marks that you can just tick off before you've even looked at the X-ray. Even if you're struggling with X-rays, you don't know what's wrong, just go through those technical aspects. And that's why it's important to have a structure, because then you don't forget anything. So here's a standard healthy chest X-ray. So you see in the center with this line, this arrow pointing down, that's your trachea, and then it divides at the carina, which is here um, near the notch of the aorta, and the carina is just underneath, splits into the two main bronchi. You can see the higher of the lungs, which are circled. You can see the heart clearly, the diaphragm, and those costophrenic angles, which look clear here. There's no signs of blunting of those angles, no signs of fluid or anything like that. You can see the pleura towards the bottom, the lungs with all lung markings, and these are normal lung markings. And then you can see the bones, you can see anterior ribs. You can count enough of those anterior ribs for your system. The clavicles are equal and straight on between the spinous, like straight either side of the spinous processes. So this is an example of a normal chest X-ray and an example of where all those structures will lie. And here's your review areas. If you once you've reached the end of your assessment and you think you haven't found anything, then go back, check behind the heart to see if there's anything that you can see in this region, check at the apices of the lung, whether there's a small pneumothorax or something like that, check under the diaphragm, and also check the clavicles if there's any breaks, anything abnormal that you can see. And even if you don't know exactly what something is, just voice it out. And your examiner might ask you, what do you think that can be? And you can go back to your kind of clinical knowledge and your differentials from that point. But if you see something that doesn't quite look right, it's better to voice it out and talk through your logic rather than to try and have everything figured out before you say something. And that's like some feedback that I've been given in OSCEs. You don't have to have 100% of things worked out. You just need to be safe in the way you're interacting with your patients. You need to have good communication skills, and you need to just say what you see. Say what you see. So here, for example, you might go through your X-ray system and find that everything's fine, and then you go to your review areas. You look at the diaphragm, and then you see there's air under the diaphragm here. So that's a sign of a pneumoperitoneum, which may be as a result of bowel perforation, stomach ulcer, which is perforated, something along these lines. And here's your A2E assessment that some of you have mentioned. Is the trachea in the midline? Is there any deviation which would suggest something like a tension pneumothorax? Widening of the mediastinum, or is there any airway obstruction? And a common place that things are obstructed is in the right main bronchus, because it's a bit straighter than the left one. Breathing, so look in your lungs, look at your pleural spaces, look for any signs of lung collapse, look for, again, signs of tension pneumothorax, even signs of a small pneumothorax, which may appear like at the top of the lungs. And I've seen this in a patient before who had small pneumothorax, and you could feel it under their skin. It felt like bubble wrap almost. And that's because they had small pneumothoraces at the top of their lungs. Is there any effusion or interstitial change? Circulation, the heart size, so the heart should be less than 50% of the diameter of the chest. You might be able to see the pulmonary vessels, but that's a bit more of a high level point. Again, the diaphragm, see the position of the diaphragm, check for the costophrenic angles, check for air under the diaphragm. And if the diaphragms aren't particularly clear, there may be fluid or a lower lobe pneumonia, which is blocking that. And then everything else, your bones, your soft tissues, your lines, tubes, which you'll commonly see when patients are unwell, and the other aspects that you might see. And here is a graph which might help you to work through differentials. If you want to take a screenshot of this or something like that. Some people find that this is a good way to work through things for them. So we've got a first case on Socrative now. If you want to jump back over to there, someone who's already answered. You have a 68-year-old who presents with 3 days of cough, producing yellow sputum, fever, shortness of breath, and pleuritic chest pain. On examination, they are tachypneic with crackles at the right lung base, but clear air entry in all other regions. What is the most likely diagnosis? Someone's asked the question and said, how many marks on OSCE can we miss and still pass the station? I think with this, it's like every OSCE station will have a different number of marking points, which will form your overall percentage. So I can't really say how many marks you can miss and still pass the station. What I can say is like the average pass mark for OSCE is like 65% ish. Um, and the way it works, I can't remember exactly how it works for fourth year, but you can fail a couple of the stations as long as you have an overall mark which is above the pass mark, effectively. Um, so if you do badly on a station, don't worry, it's not the end of the world. I failed one of my stations last year as well. But the next every station is independent from each other. So if you do badly on one station, the examiner in the next station has no idea how you did in the previous one. So if you just take every station by itself and try not to get knocked too much if you have a bad station, although of course that's easier said than done. And more likely than not, you don't know exactly what the marking points are like. So if you have, a difficult patient or you have an examination that you're not super good at, but you do everything you know and you try your best, there's a pretty good chance that you'll still pass it. Um, so it's not a case of worrying how many marks you can miss on and still pass a station, but just try and do the best that you possibly can. And you'll be surprised that some of those stations that you think you're struggling with, you'll still pass. But yeah, you guys all got it right. It's a community acquired pneumonia. And this is an image example of a pneumonia. I was quite surprised when I first look at chest x-rays that pneumonia can kind of have a few different appearances. But here we have a middle lobe pneumonia. And I think the most important thing is to describe it as an opacification. There's a shadowing in the right middle zone. Don't say lobe because it's better to say middle zone because it looks like it's in the middle, but you don't have to remember the lobes of the lung because obviously there's three lobes one side, two lobes the other side. So, but if you say middle zone, that's always going to be a correct description, whereas middle lobe, it could be an incorrect description. And there's not really any volume loss in a pneumonia, but you get this shadowing, and you can kind of see it has quite a clear border with the one of the horizontal fissures in the lungs here. So yeah, this is just a repeat. If you're unsure, don't try and guess which lobe a pathology is in, and of course, pathology can be across multiple lobes as well. It's best to just say a zone, upper middle, lower right, lower left, wherever you see it in the image. That's the best way to kind of go about it. And the next question, what components make up the common scoring system for pneumonia? Next question on Socrates. So this one came up in, I think pretty sure it came up in my OSCE. So I think we had to assess that score kind of based on the clinical information we were given. And we also had to talk through a chest x-ray with an examiner. So if you can just remember a few of them, just send a couple of them. Yeah, all very good answers, all come in at exactly the same time. So confusion, urea, respirate, change in blood pressure, new onset confusion, and age above 65 years old. Very good. So here is them all. Cub 65. I think all things in medicine should be named like this, to be honest. So you can just go through the mnemonic and have the answer. There's this syndrome in women's health in fifth year that's called HELP syndrome, HELLP, and it's exactly the same. Each letter is one of the kind of diagnostic indicators that you investigate. So if I had to bring change into the world, that's what I think I would do. But anyway, confusion, urea above 7, rest rate above 30, blood pressure below 90 systolic or below 60 diastolic, and your age above 65. And I would recommend learning this, especially because there's a nice mnemonic that goes along with it. And it seems like plenty of you have learned it already. So keep that in mind for both your OSCEs and your AKT. So in terms of pathogens which might come up, and this is particularly important for AKT questions, you can also have weird stations. I think we had a pretty weird station last year, which was supposedly Legionella pneumonia. Um, I'm not sure whether that's actually what it was or that's just what the talk around the year was, but you can get weird presentations. If you don't get the diagnosis, that doesn't mean you fail the station. Again, everything's about being safe on day one of F1. If you go through your process, you go through the process of your history, you go through the process of your examination, even if you don't get the final diagnosis, just always make sure, go through your process. And in fact, it works the other way around. Even if you know the diagnosis immediately, still go through the process because you need to show the examiner you know how to take a good history, you know how to do a proper examination. Um, and most of all, that you're safe. So, therefore, always screen for your red flags, fevers, weight loss, night sweats, and any other things which may come up based on the specific, presentation. But yeah, pathogens, pneumonia in an alcoholic, most likely pathogen is Klebsiella. Pneumonia in COPD, most likely is Haemophilus. Most common pneumonia is strep pneumoniae. Um, I think this is one of the only types of infection that comes up that Staph aureus isn't a normal cause. Legionella pneumonia, you get SIADH, deranged LFTs, and you measure using the urinary antigen. That's your first line assessment. Mycoplasma pneumonia, it says here use a serology, and you can get erythema multiforme with this as well. Viral, it can be COVID, it can be the flu, and then fungal infections, you only really get in your immunocompromised patients. So that will come up in the clinical vignette before you go into your OSCE or in your AKT, more likely. I don't think they'd give fungal pneumonia in an OSCE, but so next question on Socrative. A 74-year-old has gradually worsening breathlessness and a dry cough. On chest examination, there's reduced expansion and a stony dullness at the right base, and imaging shows fluid around one lung. What is the most likely diagnosis? I've been a bit mean by not giving multiple choice options, to be fair, but take a guess. Yep, yep, very good. Everyone got the right diagnosis, which is pleural effusion. A couple of people said pleural effusion specifically secondary to a tumor. Pleural effusion doesn't have to be secondary to a tumor. There's a variety of things which can cause um, a pleural effusion. Cancer is one of those, definitely, but it's always important to keep a wide differential. So when you just have a pleural effusion, in your exam, you'd always want to give like a couple of differentials, ideally three. So to give you a couple, pleural effusion, it could be as a result of congestive heart failure, could be as a result of underlying pneumonia, could be a result of a pulmonary embolism, and like all of you said, it could be secondary to a tumor. So just don't necessarily always have to dive down the cancer route, but if your history would have, fevers, um, maybe like some fevers and history of unexplained weight loss alongside with these symptoms, then maybe we would be leaning more towards the cancer direction. So key things with pleural effusion on your chest X-ray, as you can see here, we have a left-sided well, kind of bilateral pleural effusion, but like it's worse on the left side. And can I convince you there's definitely blunting of the costophrenic angles, and there's almost like a meniscus sign, like um, that shows the fluid level. You have the mediastinum may shift to the opposite side if the effusion is very, very large, and the effusion can also work its way higher up the lung as well. And to give you uh, a volume, 200 milliliters of fluid is needed for an effusion to be seen on chest X-ray. So you have a pretty significant pleural effusion already by the point that you can see it on a chest X-ray. So yeah, like I was saying earlier, think about the underlying pathology. Heart failure is probably the most common one you guys will see, infection and a cancer. You can determine the cause with a pleural tap. So you have your transudate versus your exudate. So your transudate occurs due to increased hydrostatic pressure or low plasma oncotic pressure. So for example, hypoalbuminemia, when there's less proteins in the blood and less oncotic pressure in order to keep the fluid in the blood vessels. So you see this in nephrotic syndrome as well, where you're losing lots of that protein from the blood. And as compared to exudative, which occurs in inflammation, you have increased capillary permeability. And as a result of that, you have exudate, which exits into the pleural space. And Light's criteria can help you differentiate between those two. So we have the next question on Socrative. A 24-year-old develops sudden severe breathlessness and pleuritic chest pain after a chest injury. They are hypotensive and the trachea is deviated away from the affected side, and breath sounds are also absent on one side. What's the most likely diagnosis? Yeah, very good. Quick answers, right answers. Um, Tension pneumothorax is correct. It's always to be suspicious of. Um, Tension pneumothorax specifically is a clinical emergency. Um, you will see the affected side being darker due to loss of lung volume. So here we have a right-sided pneumothorax, and I'd argue you can see that the lung markings are kind of peeled away from the chest wall, and you have this kind of visible edge away from the lung. There's some numbers here which you don't need to know these numbers, but just out of interest to differentiate a small versus a large pneumothorax. Advice after any pneumothorax is to stop smoking, don't fly until you've had your chest X-ray checked, and don't scuba dive because the pressure differences can cause that to recur. Um, a tip to check for a fractured clavicle ipsilaterally if this is a result of a trauma. And there's a variety of causes of your pneumothorax. Again, on examination, your most important things will be tracheal deviation. So always remember that in your assessment. Um, that will be like your barn door kind of pneumothorax presentation if you have that tracheal deviation. If primary with no existing lung disease, maybe as a result of trauma, it might be iatrogenic, so as a result of central line or ventilation. And secondary causes, if you have pre-existing lung disease, connective tissue disease, infection, these can all be causes of the pneumothorax. Here's your tension pneumothorax chest X-ray. The management is urgent need of needle decompression. I think there's been some conversation recently over which is the best place to do this. But needle thoracostomy, second intercostal space mid-clavicular line, or fourth to fifth intercostal space in the mid-axillary line. So that's called your triangle of safety. You can get mediastinal shift, but the concept is a tension pneumothorax should never get to a chest X-ray because it's a clinical diagnosis and they need urgent needle decompression or finger thoracostomy as well. And you'll hear absent breath sounds on the side of the decompression, and you will have tracheal deviation, profound tracheal deviation. So those are your key points now. The next thing is heart failure. So you have your A to E for heart failure as well. You have this bat's wing edema in the alveoli. You have curly B lines, which, depending on who you talk to, will tell you whether they exist or not. I'm not entirely sure that this arrow. Well, there are these lines you can see. These are like what you would describe as curly B lines, but even cardiologists, I think, they argue between themselves whether they exist or not. Cardiomegaly, so you'd see that the heart would be larger than 50% of the chest wall. Upper lobe diversion and bilateral effusions on both sides. So this is probably the most common cause of pleural effusion that you will see, maybe liver cirrhosis as well. And then you start the patient on ACE inhibitors and beta blockers for cardiac support. Here we have lobar collapse, and you can see it in the right upper lobe. And you have opacity with no air involvement here. The lung markings have moved away from that area of the lobe. The hilar and the fissures are pulled towards the collapse because you can imagine there's a significant pressure changes. And then you have kind of retained heart borders. Every lobar collapse looks different though, and you have to think about the structures which are being pulled towards the problem as a result of changes in pressure. But I think generally lobar collapse, you can kind of spot that there's something going on. Potentially you could confuse it for pneumothorax as well. That might be on your list of differentials. But this one is lobar collapse. Case 6 is a misplaced NG tube, and this is one of the reasons why a chest X-ray is always done after NG tube placement, to prevent iatrogenic aspiration pneumonia, known as a never event. And even though it has happened, I think a lot of doctors have stories. They know someone who knows someone that this has happened to previously, but it should never happen, and that's why we always do a chest X-ray after this now. So of course, NG tube, we want it to go into the stomach here. It's into the lung. Case 7 is lung nodule and masses. So we won't go through this for the sake of time, but here you have multiple bilateral, well circumscribed round opacities. So this is cannonball metastasis from renal cell carcinoma, testicular carcinoma, or GI thyroid breast cancer, which have metastasized to the lungs. And cannonball metastasis is a thing that you'll see in questions. That's kind of your statement as well. Here we have COPD. Main thing you can see is hyperinflation. The lungs take up a massive amount of this chest X-ray. Both lungs appear darker. There's flattening of the diaphragm. and this is what you describe as your barrel chest. Pleural plaques, thickened pleura due to asbestos exposure. This is a pretty rare one. I've actually never seen this before until this PowerPoint. But you have a patchy appearance with well-defined edges. You may be some calcification, and it's not defined by the lobes of the lung. And then this one is a mastectomy. So don't get confused in the exam thinking that there's like an opacification or something like this, because always check for the breast shadow if it's a female patient, so you can differentiate this from anything going on in the lung or differentiate from the underlying tissue. So here you have the breast tissue on the right hand side, but there's no breast tissue on the left hand side as a result of a previous mastectomy. And finally, a whiteout. So if the mediastinal shift is towards the white lung, then we have a pneumonectomy or a whole lung collapse. And if the mediastinal shift is away from the right lung, then we have a massive hemothorax, so bleeding into the chest cavity or into the lung, or an extremely large pleural effusion. Oh. And if we have no mediastinal shift, then it can be a whole lung pneumonia, which isn't unheard of at all. So to reiterate back to your structure, always check patient details and always do your wipe at the beginning of your station. Check the film details, check the position, check your technical aspects, check your key structures in your A to E approach. And if you can't find anything, then go through your review areas and see if there's something hidden. I think for the sake of time, we only have 13 minutes left, so I'll just zoom through abdominal x-ray so you guys can all get on with your Friday nights. So abdominal x-ray, same concept, always introduce some of your technical aspects with abdominal x-ray. Orientation is usually supine and projection is usually AP. So the patient is usually lying flat on their back while abdominal x-ray is taken. However, you can do an erect abdominal x-ray, so standing up, if you're looking for free intraperitoneal air, so you're looking for pneumoperitoneum, for example. Yeah, like I said, your projection is usually AP. Penetration, so you should see the spinous processes and the psoas shadows, the psoas shadows being of the psoas muscle, and rotation. So you want to be able to draw a line between the ASIS and the spinous processes and see that they're on the same level. What to look out for? Look out for gas. Look for the pattern within the bowel. See if there's any gas outside the bowel, under the diaphragm. Sometimes you'll see gas kind of along the sides of the abdominal cavity, which is kind of not compressing the organs inwards, but you'll see the organs kind of pushed away from the abdominal wall slightly. And also calcifications, which can form any of these classifications. It's great if you can remember these words and you can remember each of their presentations. But in an OSCE, if you said, I can see calcifications in the kidney, I can see calcifications in the ureter, or something along those lines, then you'll be absolutely fine. And that's a completely valid exam answer, which will get you the marks. What else to look out for? The soft tissue in the bones, liver, spleen, kidney, ureters, bladder. Your psoas shadows from your psoas muscle should be bilateral if you can see them. Otherwise, you might be suspicious of a retroperitoneal bleed or a tumor. I doubt that would come up in an OSCE though. And exogenous things, you can check for a feeding tube, you can check for a Rouse tube for gastric drainage and aspiration, which might have a radio opaque tip. So first, abdominal x-ray. This is small bowel obstruction. You have dilated small bowel loops. I honestly have no idea how to pronounce this word, but valvulae coniventes. In the small bowel, these lines go all the way across the bowel. So you can see, even though the bowel is dilated here. Those lines, they go all the way across the bowel, and you can almost follow the bowel down in its different rotations, following those straight lines. The small bowel is generally more central, generally has tighter turns, but the best rule to use is to look at those lines. Presents with colicky abdominal pain, bloating or distension, and vomiting plus plus plus. So small bowel obstruction, or if you have a patient profusely vomiting with bloating or distension, then you could think small bowel obstruction. And also they may have green vomit as well if there's bile involved, depending on what level the obstruction is. Case 2, we have large bowel obstruction. So this specifically is coffee bean sign, which is the sign of a sigmoid volvulus. So the sigmoid has twisted on itself. You get massively dilated bowel loops. And your lines in the large bowel are called haustra. They're more widely spaced than in the small bowel, and most importantly, they do not extend all the way across the bowel. They only extend part of the way across the bowel. The definitive diagnosis for large bowel obstruction requires CT abdo-pelvis, and that helps to inform surgical management. And the key thing with your large bowel obstruction is you'll have absolute constipation. Usually very little output at all. And if any, it will usually be an overflow diarrhea type presentation. Case 3, pneumoperitoneum. So this is what I was describing earlier, where you can, if I can convince you on the patient's right, you can see air around the side of the liver edge, which is kind of pushing the liver away from the abdominal wall. And if I can convince you the same on the other side, which is pushing the stomach more medially than you might expect in a normal abdominal X-ray. So this is a medical emergency. It's suggestive of a bowel perforation or a gastric perforation of some kind. And it usually requires urgent surgery, I think, in maybe 90% of cases. And if I can also convince you, if you take kind of like a step back and look out at everything in this chest X-ray, you can see that the patient looks very bloated, almost as if there is air in the peritoneal cavity. Case 4 is renal calculi, and this will present with sudden excruciating cramping pain. The pain can be in the back and the loin area, but can also radiate to the groin. You get nausea, vomiting, urgency, and hematuria. And I think people say these renal stones are the most painful thing that they've experienced in their entire life. So you can see the renal calculi here. And I think the gold standard investigation for this is CT kidney ureters bladder, CT-KUB. So I said it in my last session as well. For the AKT, the most important, for fourth year AKT, the most important thing you guys should know is to know when you have a clinical presentation, what's the first line management and what's like the gold standard management. Because those two things come up a lot in questions. I think last year there were so many questions which the answer was it CT scan, was it MRI scan, was it X-ray, was it ultrasound, that kind of thing. So I think just get comfortable with knowing your management in these last couple of weeks. And again, that also informs OSCEs in terms of your approach once you finish your OSCE, you finish your examination, and then you do take a full history, complete the 2 closest exams, and then do your investigation steps by bedside, blood, and then any kind of imaging bits you can do. And finally, case 5, last one of the day. This is a bit zoomed in, this image, but if I can convince you, you have your spine and your spinous processes here, and then you kind of have this track-like calcification that you can see around the outside, which is almost forming like a circle, really, it kind of looks like. So this is track-like calcification in the walls of the abdominal aorta. caused by atherosclerosis concurrent with a ballooning AAA. And your key things to know about AAA, again, I think this case specifically is less likely to come up as an abdominal X-ray in an OSCE setting. It will be more likely to be small bowel obstruction, large bowel obstruction as your main abdominal X-rays. So just know the difference between those two. But for AAA, abdominal ultrasound indicated. If it's larger than 5.5 centimeters, then do surgery. I believe if it's like 5.5 to 3 or something like that, it's worth checking the guidelines. But you have to follow up every year to see if it's increasing in size and increasing over that 5.5. You may do an abdominal CT to inform surgical approaches, and I believe there's routine screening for AAAs in 65-year-old men in the UK at the moment. So that's it. That is chest X-ray, ABG, and abdominal X-ray crash course. Please fill out this feedback if you what things you liked, what things you didn't like, what things could be done differently. Sorry we didn't get to do the Socrative for those last few questions. But yeah, I hope you guys enjoyed and want to wish you all the best of luck for your exams in a couple of weeks. Based on the answers you've been given to the questions today, you guys are going to be absolutely fine. But just keep on it over the next few weeks. You guys are nearly there, and then you can have one of the most satisfying summers, which is your first 2 week summer of medical school. So enjoy that. But yeah, please give us feedback so we can make these sessions as best as we possibly can for all of you. No worries. Thank you for coming.